Welcome to Peers Victoria's Speaker Series, Out of Harm's Way, Insight, Innovation, and Action on the Toxic Drug Crisis. This is the second of 3 events that Peers is hosting on the crisis, which was declared a provincial emergency more than 8 years ago now, but continues to kill 150 to 200 people a month. These photos that you're seeing up here have come from Mums Stop the Harm. There are 300 faces of people, of loved ones who've died in the overdose crisis. And we're just here to, we love the feed to bring them into the room for this conversation. We opened the series January 29th with panelists who brought us the history, context, and complexity of this issue, as well as the University of Victoria, which provided a really fascinating chemical analysis of what the modern street drug looks like these days. Today we have 6 local organizations bringing us their own perspectives around the work they do to intervene in the toxic drug crisis. And we'll follow that up with an expert dialogue on evidence and the moral panic that stops us from doing what the evidence is telling us to do. That panel will explore what we are and aren't doing to address the crisis. We use the phrase overdose a lot to talk about what's going on. One of my friends said, I don't think you should use overdose because it sounds, kind of like as though someone almost deliberately took too much. So, I mean, really at its essence, the toxic drug crisis is about seriously potent opioids like fentanyl being acquired from unknown and unregulated sources, sold in unknown quality and quantity, and with no guidance on dosage. So what we've got happening, in other words, is a synthetic drug supply manufactured out of bits and pieces of everything from anywhere, put together by someone in an unregulated facility with no oversight, and sold with zero certainty on anyone's part as to what might happen to the person using the drugs. Whether you're a first-time user or a veteran, anyone's life is at stake in a situation like that. The people you'll be hearing from today work on the front lines of this reality. They bring much wisdom and experience and much passion. It's fascinating to see the people who have been in this 10, 15, 20 years longer. They're still leading the discussion on this one. Before we get started, I'd like to acknowledge this event is taking place in Lekwungen territories and invite Rachel Atleo of the Songhees Nation to share some words and Sean Bartleman of the Sartlip Nation to share a song. As we move through the proceedings of the day, it's important to remember whose territories we are in and to consider how displacement from homelands and culture is interwoven through the opioid crisis. We're very grateful that Rachel, Sean, and our Cedar Brushers, Johnny and Sophia, who are set up in the room across the way, have agreed to join us today. Rachel and Sean, would you like to come up?
Asiam Nistrelicha, Asa Rachel Atleo, Chisa Ethlison Ut Lekwungen, Aishka Quans Ene Ethla Atia Enoch, Aikwan Stachel at the Elangang at Lekwungen, Aikwanis Quananga Hela, Aishka Siem. My honorable friends, I am Rachel Atleo. I am from here, Lekwungen. Thank you for coming here today. Welcome to the home territory of the Lekwungen people. It's good to see you all. Thank you, honorable ones. Thank you for asking me to welcome you all with the work you do in a humble way. Enjoy this afternoon and hope your journey home is safe. Aishka Siem.
We've got two brief keynotes to open this big conversation today. I'd like to welcome community social impact leader Trevor Botkin up as our first speaker. Trevor's a passionate public speaker who has shared his lived experience of addiction and recovery, mental health, stigma, and the social constructs of masculine identity on many a stage. He's also a Red Seal carpenter and the manager of industry relations for the Construction Foundation of BC, where he's helping to open up a very interesting conversation in the trades and beyond about drug use and the risks of a toxic drug supply. Trevor, welcome.
I just started working on that introduction. It's a lot to live up to. I'm Trevor Botkin. I've worked for 30 years in the construction industry, about 25 of that directly as a carpenter and a superintendent. After that, I moved into the charity space in about 2018, largely trying to change everything outside of here so I could exist on this planet. It wasn't the answer I was looking for, but it sure has been rewarding and something I'm passionate about to this day. So, we got so many different crises going on all at the same time right now. And the construction industry in Canada has a suicide rate that's more than 3 times the national average. I think it's that way for a number of different reasons. We're not going to get into all of them today. There's a ton of stuff going on in an industry. It's relied and built on the backs of people that are quite often socially disadvantaged or from a socioeconomic standpoint. We don't come in there from our wealthy families necessarily. We are not coming there because I'd just rather not be a doctor or a lawyer. We're coming into there often because of our circumstances, the results of our upbringing, and where we come from. And sometimes, a lot of the times, and I work a lot in my day job with this, is because of learning disabilities and stuff like that. We don't fit into standard systems. So there's a lot of reasons this number is so high amongst construction workers. The rate of substance use in construction is nearly twice the national average. So the relationship between substances and construction workers, if you include alcohol especially, is as old as time immemorial. There's a hard job, there's a cowboy spirit and culture. We've always medicated. We've always done it en masse. It's a very common thing in the industry. The challenge right now is the consequences are incredible. They come incredibly swiftly, unpredictably, and they can be absolute. Since 2016, 30 to 50% of employed victims of overdose worked in the skilled trades and transport. So of those employed, and it's really hard to get solid numbers on this, more studies has to be done. It's warranted and needs to be done. We're hoping to address some of that with some of the projects we're working on. But it's a troubling number, right? These are crisis numbers. I want to introduce you to Matthew Arnold. This is a tough one for me. Matthew worked for me in 2016. He was a young guy. This wasn't his first career choice. He had tried some other places, struck out. He ended up, like many, knowing he could make a good living in the industry. He came to us. I wasn't his first boss on site, but he was probably a year and a half, 2 years into his apprenticeship. He's a great guy, a lovely man. When it come to his fitting into the job site and into the camaraderie and the spirit of the crew, he stood out because he was very kind and generous. He didn't speak as confrontationally as we did. He wasn't as aggressive as we did. And people actually enjoyed that, responded to it very well because he was always there to be of service. And when he asked you a question, he cared about the answer. He would listen. And when you were having a problem and felt overwhelmed, Matt would listen. He would care, and he might offer his solutions. He's just a beautiful guy. Things went south with Matt. Around November of 2016, things started to shift. His energy shifted. The way he showed up on the job site shifted. He was becoming clumsy. He was creating dangerous situations for himself and his co-workers. Unfortunately, I had to make the decision to let Matt go. Today, to this day, as I stand here, I made the right decision. His safety and the welfare of others on the job site was wrong, but I knew what was going on. Because I had a lot, I suspected at the time, it was confirmed later, I had a lot in common with Matt. I too was suffering from a spiraling addiction. Matt sent me this message. I let him go probably around the 15th to the 19th of December. On the 23rd of December, he sent me this message: missing you and the rest of the crew. I hope that you've had a damn good Christmas, or you have a damn good Christmas and New Year's tree. Thank you for being awesome stand-up foreman to me while I was under your tenor. Several days later, Matt died. He was found on his mattress, face down, alone, nobody with him. Accidental or intentional, we will never know that answer. But it happened. Now you notice where this is cut off, and it might be easy to assume that I've cut off my response because I didn't want you to know how personal it was and how I reached out to him, and I didn't respond to that message. I knew he was in a tough way. I had to let him go. It broke my heart to do it. And when I got that message, I didn't respond. Was I distracted by my own situation? I don't know. Was I minimizing the impacts of his termination, how I responded to his struggle? Probably. I didn't have the tools, I didn't have the awareness of my own situation, or I had no awareness around mental health. I had absolutely no way to connect with this guy, to have that conversation safely for him, safely for me. I was protecting my job. I didn't want to get fired. I was his leader. I had this stubborn sense of masculinity that I was trying to live into every day. I was trying my best to live the alpha male role of leadership, whatever that is. And instead, I should have been, as I'm trying to do now, living into a shepherd's mindset. So imagine the irony and how many times Matt's story played through my mind up until March 6, 2019, where I was waiting for my mother to go to work so I could back my Jeep into the garage and just end it. I was done. I was done with the misery and the despair I'd been suffering in. I had nowhere left to turn. I had nobody to talk to. I thought I would lose my job and my reputation. I would let people down. I didn't think I could talk to my coworkers because I couldn't talk to Matt. I'd seen it 100 times play out before, where guys struggle, they drown, and nobody is there. And that's what I tell myself. That'll be me. That's what's happened. There's nothing for me. Nobody gets me. The challenge of the construction industry is that we come in there believing that's the only place we belong and fit. When I got there, I had been bullied I love this shirt. I'd been bullied my whole childhood adolescence. I didn't fit in. I didn't go serve well. My first day on a job site, I was like, these are my people. This is where I belong. They had me, and that saved my life, to be honest. But one of the challenges with that ideology is that you start to tell yourself that nobody else understands you, nobody else would get it, nobody's cut out for this job. And all those supports and things out there to help me aren't for me. 6 years into recovery now, I can see that I wasn't going through anything that other industries don't. For frontline responders, people working down on the downtown core, very frontline. We all get into the space where we feel we belong, we're passionate about it, and we feel people don't understand. I can see that now, that shared humanity. But in construction, it's shielding us from accessing support. I don't live with regret anymore, but I do live with a passion, and I'm so glad I've been able to have this conversation with Matt's mom, that I can take this experience and do something to help this industry, the place that gave me a career and a life and put food on my kids' tables. I no longer live in the shame and the stigma of my drug use. I understand what was going on. I've got a community around me now to support me in my recovery, sustained recovery. But the most common question I've been asked, and I worked on projects across the country with the governments and organizations, the question I get asked the most is, how do we get through these guys? We've built this awesome tool, we've built this awesome training tool, we've got this program, we've got this counseling, we can manage pain, we can do all this stuff. These guys aren't taking the help, they're not seeking the help, we can't communicate with them. And I'd respond back, You got to speak their language. They got to respect you. They got to know where you are. They got to understand, like, trust you. They got to feel that you've seen something they have. It's no different for police officers, for paramedics, for firefighters. But the suffering we celebrate in the trades, the rolling up our sleeves together, that camaraderie of getting the physicality of the job, I think just takes it to another level. But it struck me a few months ago that what I was talking about, what I was describing, was essentially peer support. I imagine most people in this room thought, well, peer support, we do that everywhere. The industry doesn't have peer support. So right now, we are working on, I have the great privilege to work with my colleague, Jenny Nadeau at CFBC, and we are building out the first of its kind peer support model for the skilled trades. This will be men and women with lived experience with both mental health and substance use, but also working on the ground in the trades. We're going to custom build a program, a curriculum with Jen Cusick that is tailor-made for these guys in their voice, in their language. So we want it to look like something that they would respond to. We're working on a direct-to-peer connection approach, a website where basically we can start getting the men and women in the trades to go to if they're struggling. This is not an emergency support. We're not trying to recreate anything that everybody is doing. We're just trying to connect with these men, have the conversations, and let them know what's available because we've been there, we've seen it, we got through it with some success. So we want to tailor-make a peer support model that works for them and that they recognize and see themselves in. The idea right now, and this is like a radically reduced slide deck, is a direct-to-peer. We want to front-load it with safety, connection, and security. When I was in my shit, I used to roam through stories of guys that had been where I was or people that share their recovery story and all this, and I would watch it, and I would come back to it a week later, and I'd watch it. I did this for like 2 years, trying to figure out what was going to happen for me. In the same vein, we want a space where guys that are curious or want to ask questions can go in and they can start reading the bios of the guys that have been there, that are doing the peer support. They can maybe watch a 3-minute video interview. They can listen to a podcast. They can start getting comfortable with the idea of this person and do I feel a relational connection to them? And then they can directly connect with them through our channel so that we can either by text, by phone call, coffee date, you name it, we can start having those interactions to get these guys talking about where they're at and what's going on for them. And so they can start asking questions about where I was at and what was going on for me and how I avoided the ultimate conclusion. Because it's possible. It's possible that we recover from this stuff. It really is. And so that's the idea I get the privilege of working on. Beyond that, all I want to say today is whether it's recovery or harm reduction, you name it, if hope, determination, empowerment, and opportunity aren't fundamentally built in to what you are providing to the community, you're not doing it right. I've seen so much confusion over the last few years, and there's so much opportunity for different perspectives to twist things and manipulate things, and people are getting impatient and people are dying. We need to address all these things when we're supporting people. And that self-determination, I've highlighted it differently because that's a tricky one. On March 6, 2019, in the absence of hope and possibility and opportunity and empowerment, I was choosing to leave this world. I was over it. I couldn't stand the suffering anymore. I even convinced myself that my family and my children would be better off without me. 40 days later, after the miracle of landing in a place that could give me the help I need and the guidance I needed, I thought, maybe I'll take a crack at this thing called life. That's all I got.
All right. Our next speaker is Dr. Ashley Heaslip. She's the Executive Medical Director of Addiction Medicine and Substance Use for Island Health and has rushed down here from her own Wednesday addiction medical clinic to be with us. Ashley, welcome.
I think so, if that's okay. Thank you. Thank you for that introduction, Jody. I'm going to stay here. Trevor set a very high bar there for presentations. Well done, Trevor. I'm going to stay here because I have some speaking notes. I wanted to say a thank you to Rachel and Sean for your welcoming today. Thank you for grounding us all, for being here together. As Jody mentioned, I'm Ash Heaslip. I'm a family doctor and addiction medicine physician here in Victoria. I've been working in low barrier primary care, addiction medicine, and outreach medicine for nearly a decade, the majority of it here in Victoria. And so, my comments and my perspectives and my thoughts that I bring here today are very much from the perspective of sort of a physician working within this space. And in reflecting on the topic for today, thinking about sort of out of harm's way, insight, innovation, and action, really made me think how we can kind of step through those pieces together, from insight to innovation to action. The spaces that I find insight around this work and around this sort of challenge that we're all faced with in society right now related to the toxic drug crisis largely comes from the patients that I have the privilege to work alongside. So I thought I'd share just a little story from a patient that I actually was able to take care of or be a part of their care of yesterday when I was on my outreach shift. It's someone that I've known for the better part of 8 years, and I've seen him in and out of a variety of sort of times in his substance use journey, before and after periods of incarceration, before and after periods of stable housing, before and after very traumatic overdoses or toxic drug poisoning events. And I had lost sight of him for a couple of months. We had seen each other in early December, and then there was a period of time where I just didn't see him again. It was about 2 months over the winter holidays, and I started to worry. It wasn't uncommon for me to not be able to see him for a period of time with those periods of incarceration and things that were, patterns in his life. But I did start to worry and started to look through hospital records and see if I could find any information that would give me an indication of how he was doing or where he was. And then fortunately, he popped up in the world and showed up in early February. And in the first interaction the two of us had, because we've known each other for the better part of a decade, I think he was able to be really honest with me about how hard things were in that moment. He wasn't able to stay and talk to me for long because there was just so much going on, but the reality that he had had a recent overdose, had been physically assaulted, and also was living with, an incredible amount of trauma that he was carrying through from previous experiences. Those were all showing up in our interactions together. So we weren't able to talk for long that first day, but then he showed up again this past week. And we were able to sit down and have a conversation and kind of figure out where things had gone in his journey in the last little while, start some medication for him again, and start to bring him into the space of care that we're able to provide. And I just wanted to share with you the words that he left me with yesterday when we parted ways. He said, "I'm really needing some kindness in my life right now. Thank you for being here. Sometimes it feels like no one is here with me." Those words are really reflected in what Trevor shared with us around his story as well too. And it got me thinking about how our system of care often doesn't see people. People are suffering. People come to us in a variety of states of needing help and encouragement and support and hope, as Trevor mentioned, which is so critical to what we do. And in this particular situation, he was sharing with me that the systems that we have and the spaces that we do have for care often don't feel like he can be a part of them. And it really made me think about that insight. How important is it to have the voices of the people who are trying to access our system or trying to be a part of our system, and for whom the system is either not there or is not the right system or not meeting them in the right way? Something that's been really helpful to me when I've been thinking through how we design a system of care for substance use, how we actually bring people into care, is this idea that I've heard many times before around patients no-showing to the system. So we'll have, an appointment booked for an intake at a detox or an appointment booked to see a physician, and People just won't be able to be there. There's a lot of reasons why people may not be able to be there, but after a period of time, our system says that that patient has no-showed us within our system. And the question I want to ask of our system is, has our system actually no-showed them? Do we have the right services in place? Do we have the right timeliness, the way to capture people in the moment, so that we're actually showing up as a system for people when they need us? And I think oftentimes the answer along the way over the last number of years has been the system hasn't been showing up. So how do we look towards creating a system that does show up for people? And one of the ways to do that, and one of the ways that it's so incredibly important that we do that, is by bringing in evidence and insight into the space of how we design our system. I know in this room today that there's a collective dedication to truly seeing people, to acknowledging the humanness of us all. Even the photos that are around us today, I'm seeing patients of mine in that space and recognizing that this is the reality. Really, at the end of the day, this is a human space, and it's a space of human need and human kindness and human suffering that's within this space. So how do we develop systems with this collective dedication that we do all have towards humanness that allow the systems to feel human, allow the systems to welcome people into it? One of those ways is by hearing the voices of people, and so for myself, it's the patients that I work alongside, bringing those voices to the center of our system. Another way is to bring in a variety of forms of evidence that we have around how we do the care well. So thinking through things like qualitative research and quantitative research and real-time public health data that we have, clinical guidance and guideline documents, all those sorts of things can help inform bringing evidence into action to support patients and to support the people in our communities who need us so much in this space. However, the public narrative around substance use has become so deeply polarized, oversimplified, and in some ways rooted in misperception or opinions that it's sometimes hard to bring that human-driven insight as well as evidence into these spaces. So what do we do to bring insight and evidence into this increasingly polarized and in some ways very politicized space that this work exists in right now? Well, we use evidence to guide our interventions while also generating new knowledge to hopefully improve the care that we are able to provide. So an example of this, and I'm very excited that we'll have Dr. Reka Gustafson on one of our panels this afternoon, but example of this is actually the Chief Medical Health Officer's report that was just released by Island Health and by Dr. Gustafson a number of months ago. It's called, the title of the report is Challenge and Change, a Public Health Response to Our Perplexing Relationship with Psychoactive Substances. I really like the use of the word perplexing, because in so many ways I think it feels that way for so many of us. The hope of having a piece of work like this from somebody like our Chief Medical Health Officer for our health authority is to really say, here's the evidence. We have this space. We know the data. The data is for the people who live in our health authority, who live on the island. We have the information we need, and we have the opportunities from that information to change things and to change the way that we're approaching how we understand the toxic drug crisis. The goal of the report really is to support conversations using data to build interventions that lead to better health outcomes. And the report, I think, really importantly identifies some foundational things that maybe sometimes we take for granted in our work, but do need to be said over and over again. Some of those things are that addiction is a health condition. We have lost sight of that in some of our conversations, and particularly some of the politicized conversations that are out there right now. It's a health condition, and it requires evidence-driven approaches like any medical condition requires. Another important dominant narrative that the report emphasizes is that people who use substances for a variety of reasons and on a spectrum of use, and a spectrum of associated harms with that use. And then finally, I think a very important point that the report draws upon is that harm reduction, treatment, and recovery are not competing or opposing strategies. They're a mosaic of strategies when brought together do the best possible thing for the patients in front of us. I oftentimes think of harm reduction as, the foundation or a safety net that sits underneath some of the other approaches that we have around prevention, treatment, and recovery. But none of those approaches are strongest on their own unless they have harm reduction at the foundation. The Chief Medical Health Report also gives us really important insight into what's happening on the island. So important pieces of information around things like there's changes in the way that we understand overdose-related deaths in the Centre and North Island versus the South Island. We traditionally have had higher rates of death in the Centre and North Island than we have had in the South Island. So what does that tell us about what we're doing in the South Island, or potentially around what the drug supply looks like in the South Island that might be different from the Centre or the North? Is there something happening in the South with a collection of services that's working well for people? And if so, how do we learn from that locally and build upon it so that we can expand that regional equity up to the Centre and the North Island? It also gives us really important information around polysubstance use, and particularly around the ongoing impacts of alcohol use as well in our communities. It's incredibly important for us to be focusing on the unregulated toxic drug crisis, and alcohol is also continuing to have dramatic impacts on people's health in Island Health. And so it's something we need to be thinking, not a one or the other answer, but that we need to be looking at multiple aspects of challenge in this space. In addition, it calls forward a number of opportunities for change that I think are really important for us to be thinking about. Everything from strategies for prevention, which often doesn't get talked about in this space, but is so foundationally important to the work, through to things like healthy public policy and dialogue around this work. It also explicitly calls out unfair, unjust, and changeable conditions of inequity that are infecting many segments of our population on the island, particularly around Indigenous individuals and communities, and the disproportionate impact that's happening around substance use within those settings. One of the things that it's an opportunity for action that has come out of the report that is near and dear to my heart is this idea of developing a system of care for substance use. So when we think about other aspects of chronic disease management in our province and in our health authority, we have systems for things. So we think about chronic kidney disease or renal disease, we think about cancer care. There are coordinated, designed, comprehensive systems that catch people, right? If someone has a cancer diagnosis in the emergency room, what does that referral pathway look like into an oncologist, into that next step of care? And then how are patients held through that process of treatment? We don't necessarily have a similar system for substance use care. There are spaces of it popping up around the province, and there's some really important work happening in Island Health around that. But can you imagine a system where someone presents to an emergency room secondary to a toxic drug poisoning, and there's a wraparound strategy, not just around healthcare, but around housing, around social supports, around outreach that can really be able to bring people into a system that will help them as they navigate whatever next steps towards their wellness that they're looking for. So I like to imagine, where could we be in 10, maybe 5, if you're really optimistic, maybe 15 years? Where could we be with a substance use system of care where patients can enter the system anywhere in the system, your family doctor's office, an emergency room, even a long-term care facility would be incredible, and be able to be brought into a system that can hold you throughout your journey and that allows for the capturing where those moments happen in a relapsing and remitting condition like substance use disorder is, that there's a safety net, a harm reduction safety net that's picking people up and bringing them back into the system when it's appropriate to do so. Some of you may have heard, it's very sort of bureaucratic language, but there is a new initiative with the provincial government called Road to Recovery, which is really intending to build up that system of care in every health authority. And we're working on that. We're working on that Road to Recovery work in Island Health as well too. And we hope very much that in the coming years, as we're able to put new services and new investments in place, that we'll be able to see that system that really captures people and that recognizes the humanness in all of this and the need for kindness in all of this. So I think it's really important that we continue to look for evidence-informed strategies, including things like our system of care advancement. How can we take the incredible data and evidence that we already have that are captured in things like the Chief Medical Health Officer's report and infuse that into the development of a system that will serve British Columbians and serve the residents of Island Health for years to come? What we say and how we say it matters. Acknowledging addiction as a health condition really does put it in a different space of our dialogue than it has appeared in sort of historical contexts where we've really seen it as a criminal justice issue. So, talking about addiction as a health condition is incredibly important, and that the opportunities for change that we have to be situated within that knowledge, within that understanding of addiction as a health condition. Our work is not just about evidence or innovation. I'm saying this to a room of people who probably all of you could be up here speaking with far more expertise in this space than I can, having lived in it and been in it for probably much longer than I. Our work is not just about evidence or innovation, it's about humans and it's about hope. So how do we continue to go back to that space that we're designing systems, we're creating change that places humans and hope at the center of it. And it's also about continuing to show up for those that we care for, as those that we care for continue to show up for us. So I had, lost the track of that patient for a couple of months, and there he was again, continuing to show up, continuing to take the stance of saying, I'm taking care of myself, I'm here to talk to you, I'm here to figure out what my next step towards wellness is. So how do we honor that incredible courage and resiliency? How do we actually create opportunities that people feel like they're having a deep connection into the care that we're trying to offer? So let's figure out how we show up. Let's figure out how that system starts to move away from that notion of no-showing and really showing up for the people we care for. And it's about continuing to use whatever voice you have to bring insight and innovation and action to the forefront of the public narrative around substance use care so that we're always ensuring that that humanness is at the center of what we do. There's such a profound public discourse around dehumanizing this space right now. So how do we consistently show up in who we are, in the language that we use that allows for the dramatic and disproportionate and profoundly tragic impact that this continues to have and places the humanness of this in the middle of it. So I just wanted to say thank you for letting me be up here. I feel really honored to even have the opportunity to speak. As I said, there's so much wisdom in this room, and I feel like I'm a bit of an imposter being up here when I know so many of you could be speaking to this in really human-driven and very experiential ways. I'm really looking forward to the panels and to having the opportunity to hear about the innovation that is happening with the organizations here in Victoria. We have a lot to be proud of in our community, and I think this is a wonderful showcase and opportunity to learn from each other as we do move towards insight and innovation and action in this space. So thank you so much.
Thanks so much, Ashley. You and Trevor really gave us that was a really good pairing. I'd like to now welcome up the people who are going to make the presentations to us about their work, their organizations do to intervene in the toxic drug crisis. Our panelists are each going to have 10 minutes. They're all going to come up here and sit in the lovely living room. They'll each have 10 minutes to tell us about the work they're doing and the successes and challenges they're encountering as they do that work. And then we'll have a facilitated dialogue for 15 minutes with them. Our panelists are Wanda Schritter and Megan Hopkins, talking about the Housing Overdose Prevention and Peer Services Program. Marlene Stevens with First Nations Health Authority, talking about Indigenous harm reduction approaches. Brent Johnson with the Harbour Supervised Consumption Site. Dr. Jill Wieczorek of Doctors for Safer Drug Policy. Emily Clayton from the SAFER program at AVI, and Evan James from Umbrella Society on connecting people to treatment and recovery. So I'd like to invite Curtis Hart up to give a brief history of HOPS ahead of that presentation. Curtis is South Island Complex Community Care Operations Manager with Island Health.
Good afternoon, everyone. I was asked just to speak briefly about the HOPS program. Just recognizing I come from Treaty 4 territory, and so very grateful to be on these unceded traditional territories of the Lekwungen-speaking people. I am an uninvited guest, and I arrived in August of 2021, and that was actually just when the HOPS programs were turning into a bit of a reality. Prior to me coming to Island Health, a few of my colleagues, Mary Morrison and Lorraine Bates, Jacqueline McKinnon, and then a number of members from the community organizations like Solid, AVI, Peers, Umbrella, a number of the housing operators, BC Housing, residents, people with lived and living experiences, were in the midst of a dual pandemic. There was both the toxic drug supply toxic drug crisis, that was occurring, but as well at that time, COVID was occurring, and we were moving into, I think, what was being referred to as the fourth wave of COVID, the Delta wave. And at that time, there had been a number of ideas that had been put in place to support a number of the initiatives that had been occurring to support individuals. And so a number of hotels had been purchased across the city to move folks out of encampments and into some form of housing, whether it be single occupancy rooms or hotels or in some cases suites. And a number of initiatives had come from that, and Island Health had heard and received some resources to be able to try and actualize services to meet the needs of the community based on what that very large group of experts in the community had identified. And so there were a few different areas that had been focused on. One of them was mobile primary care, which some of our folks from Kool-Aid offer at a number of the supportive housing sites. Another was around counseling and mental health supports, and so there's a team called the Health and Housing Team. And then the third was the HOPS programs, and that's the Housing Overdose Prevention and Peer Services that is contracted with Umbrella, AVI, Peers, and Solid. And it's not very often that health authorities are granted a sum of resources to be able to identify opportunities in the community to support, and it was a very blessed opportunity given the circumstances in trying to address a number of needs in a very unique way. And so at that time, the Health and Housing Think Tank report had been completed, identifying a number of different areas to be able to support that. And then we moved from having overdose prevention spaces and peer services contracted separately to the HOPS model. And in by October 1st of 2021, we were looking at having these services implemented. And then that's really where the hard work occurred. The housing operators invited us into their spaces to allow the HOPS providers to begin delivering these services. And a number of these sites had been identified based around the ambulance responses and the fatalities due to the toxic drug supply at these sites. And so we were able to take the data that Dr. Ash Heaslip had referenced and be able to identify a number of the areas and locations within the city that were really identified as requiring some supports and look at some creative opportunities and solutions to provide services to members of the public. So just recognizing that I can be a bit chatty when I'm nervous, I'll wrap it up there and hand it over to the real experts.
Thanks, Curtis. We're all chatty when we're nervous, I think. Okay, I'm going to give Megan this mic, Here's Megan and Wanda to tell us more about Hobbs.
Thank you. Hi, everyone. It's so nice to look around and see so many friends here. My name's Megan,
I'm Wanda.
and we work with peers in the HOPS program. So the HOPS program is integrated into many of the supportive housing sites in the city, and we know from working in these sites and from the data collected through our own surveys that the majority of the residents in these supportive housing sites are using substances, many of whom are substance dependent, and a high proportion of these folks are using down daily or weekly. Recent data from the BC government says that in 2024, 1/3 of unregulated drug deaths occurred in social and supportive housing, which is why we know that this is such a critical environment to focus on for harm reduction and overdose prevention and other supportive interventions to reduce harm and improve the well-being for people who use drugs. So Wanda's going to talk a little bit about how the HOPS program intervenes in the OD crisis.
So our HOPS program is run by 4 contractors, AVI, Peer, Solid, and Umbrella. And we provide the program in 12 supportive housing buildings operated by PHS, Solid, Our Place Society, Beacon Community Services, and Aboriginal Coalition to End Homelessness. We're staffed with 2 staff, 5 days a week, 7 hours a day. We do social support, connections to services, access to harm reduction, access to basic needs like toiletries, food, drinks, clothing exchanges, being with people when they consume, and creating safe consuming spaces. This could be by checking on people, facilitating communal consumption space, and several other methods for making sure people are not using alone. A major thing we do is create connection and social spaces because we know that isolation and lack of individual supports are a big factor in the overdose crisis. And we offer individual supports such as transportation to services, help with moves and accessing healthcare, and justice appointments, among other daily individual supports. In addition to offering resource rooms and social support spaces, the other major activities of the HOPS program is resident engagement and training. In every building, there are 5 or more people at any given time. Positions rotate among residents who live there and are paid with stipends to take part in training to be responders in their community, recognizing that residents are most often the first to notice or respond to an overdose. Resident responders take part in first aid and a varied curriculum of training to support them to both help others but also cope with the stress and grief of being first responders in their communities. These individuals are distributing naloxone harm reduction supplies, talking to other residents about safer use strategies. There are also daily positions in the buildings where residents can help oversee common consumption spaces, cleaning of consumption spaces, facilitating drug checking, and posting information about the supply. There is usually regular trainings for the whole resident group, such as monthly overdose response training, social events like birthday celebrations, holiday parties, and unfortunately the HOPS program are often hosting celebrations of life for residents who have passed and connecting with families.
As you can see, the HOPS program is quite abundant. There's many layers to it. We have many different programs kind of operating within the program itself, and different ways that we create connection among the employees and the peers and the residents in the building. We want to talk a little bit about some of the primary outcomes that we're witnessing while we're doing this work. So first of all, we noticed that we definitely build up resident knowledge in the housing sites. We'll have workshops on trainings on anything from Narcan training, like advanced overdose prevention, Indigenous harm reduction, gender-based violence. And we often see the residents attending these trainings and then coming to the office and talking about it with us as well, and kind of trying on that new language that they're learning, or saying like, oh my God, I had no idea about that. And that's just so incredible to see. It's so incredible to see them amongst themselves having these discussions and talking about many of these complex issues. We also provide training opportunities and a chance for people to give back. So as Wanda was saying, we have our resident responder program. And I think it's probably one of the most important programs that we have. We always hear people telling us that it feels like it gives them a sense of purpose and it acknowledges the way in which they're contributing to their community. So that's something that we're really proud of and we want to continue doing so. We also really pride ourselves in being accessible and non-stigmatized. If anyone's ever been into some supportive housing sites, there still can be that kind of stigmatized vibe, to put it lightly. People still have a lot to learn in these roles that they're taking on, working with such marginalized populations. And so we really pride ourselves in our offices as being a place where people can come. We notice that people who maybe never used to talk about their substance use or had fears about talking about it will now be coming into the office and having more open conversations about substance use, about safer practices, and we see the connections being made with the residents and the neighbors as well. So that's really amazing. We do provide a lot of individual social and health support to people too. People come to us oftentimes to vent or to talk about their grief, also talk about their joy. People sometimes need reminders for their appointments coming up and stuff like that, so we'll give them a little call on the phone or put it in our calendar. These kind of everyday things that we kind of take for granted as people with iPhones and Google Calendars and all these things that can really be effective and make an impact in someone's life and keeping them connected to healthcare and other services. And also we see ourselves building partnerships and sharing knowledge with other sites, the housing staff, Kool-Aid, and others, just kind of depending on the building and who's coming through and who we're meeting with. I would say ultimately, we really believe that we're contributing to reduce deaths from overdoses and better and more rapid response to overdoses within the building. And we think that this is because of the increase of knowledge, the reduction of stigma, the reduction of isolation. There's often a common misconception about harm reduction that it's simply about handing out sterile, safe use supplies or overdose response. But we really believe that joy is harm reduction, connection is harm reduction, community is harm reduction, safety and dignity are all part of harm reduction as well, which I believe we're providing a space for all of those things. And we also know it's kind of hard to collect data on that as well. It's a lot easier to see numbers of people who are dying, unfortunately, than it is to see people who are not dying, right? You can't get those numbers and capture it in the same way. You can't necessarily capture the joy or the social connection, but we definitely see it every day in the work that we do and the people that we're working alongside. And yeah, it's an amazing, amazing program, but of course there's challenges, so we're gonna speak a little bit about that too.
Yeah, so I think some of the challenges that we face is that it's not like a 9 to 5 time that people are using. So it would be nice to like have our services there 24/7, like especially at night when there's less staff, less people around to help, less things for everyone to use. Also, it's like difficult to convince people not to use alone with substances, especially with stigma that goes along with it. And also we would need, it's nice to have like a consumption space with designated spaces for everyone to use and that were like by the people who use and run by the people who use substances.
Yeah, given that substance use is a primary, if not the primary, health condition for people who are living in supportive housing, we really believe that buildings need to be outfitted with the appropriate facilities and that this should be mandated and supported with policy and standards at the highest levels of the Ministry of Health and BC Housing. We are seeing buildings being built that don't have these spaces available for people, and we know through the work that we do that people do use these spaces, especially when they're designed by the people who use drugs as well. So we think that's something that's really important moving forward as we continue to build more housing for people, which is obviously so very needed. We'd also like to see more access to safer supply and prescribed alternatives so they're actually truly accessible for people. We know from talking with people that they do want these services, but people still continue to experience massive barriers, and we want to find ways to make them more accessible. We also want to see more diverse and accessible pathways to recovery. It seems that there only seems to be one linear pathway right now, and we know that that doesn't work for most people. And there's so many possibilities that we can all dream of and imagine that we could make a reality if we all could find the funding for it and put our heads together. And ultimately, we want to see the decriminalization of substance use. We want to see money put towards an expanded health and wellness response that actually truly meets the needs of people who use drugs in a way that is dignified and really supports their well-being. And lastly, we really feel that we need more eviction prevention and destigmatization work in the context of supportive housing. Many people are coming into these jobs maybe without the knowledge or understanding, not necessarily with the lived experience, and it's a disservice to the people working in these buildings to not offer them that kind of education around destigmatization and non-judgment. It is still the case that we do not have enough housing. I think we all know this. And this definitely contributes to a system where housing is precarious and treated as a privilege and not a right. We know that housing is a human right. We need more housing. And people deserve to be secure in their housing as a foundation before they can address their other health and wellness needs. Ideally, we want to see all programs and services influenced and designed by and for people who use drugs to ensure that the programs that we are creating and evolving are truly meeting the needs that they have. Thank you.
Thanks.
Thanks so much, Megan and Wanda. I'd now like to invite Marlene Stevens up for First Nations Health Authority.
Good afternoon, everybody. I wanted to thank Sean and Rachel for giving us that traditional welcome to the territory. Gisakyukit hugaklik los husukalkukni nausan mietki zuhugaki gaki akiskunuk. Good afternoon, everybody. My name is Marlene, and I come from the traditional territory where Windermere Lake meets Columbia River, otherwise known as Invermere, BC. I am the Indigenous Harm Reduction Educator with First Nations Health Authority. I wanted to start by saying I had an interesting question asked of me the other day, and the question was, is First Nations Health Authority a band? Is it a First Nations reserve? And this was from a non-Indigenous person, and I thought, wow, okay, this is an interesting question. And I said, no, First Nations Health Authority is the equivalent to all the health authorities in BC. And they said, oh, it's not, I've never heard of it before. And I thought, oh, okay, this is a beautiful conversation. And so I let him know about First Nations Health Authority, that we've been around for pretty much as long as I've been living. When I was growing up in the late 70s, my mom became a part of First Nations Council, and back then it was called First Nations Chiefs Health Committee. And my mom was on that, and she was one of the people who began to dream about First Nations Health Authority, and that coming to be that over time we would have our own healthcare system, and we would be able to take care of all of our First Nations people in the way that we know how best to care for our people. Fast forward, First Nations Health Authority came to be, and they are an equivalent to Island Health Authority, all the other health authorities throughout BC. So I came to First Nations Health Authority in 2021. 2020, I was hired during COVID, and I started out as a child and youth care worker, and when this health harm reduction educator came to be, I knew that the experience that I had lived would definitely fit that position as a harm reduction educator based on the experience in my life. Part of my training was I did some cultural safety and humility training, the SANYAS cultural safety and humility training, but I also had to, because I was going to do a train the trainer with the Not Just Naloxone training, which is a 2 to 3 day presentation around how First Nations people came to the toxic drug crisis. And so we talk about contact, we talk about prohibition, we talk about colonization, we talk about Indian residential schools, and we talk about a whole lot of other topics that have impacted our First Nations people. We definitely, Dr. Heather was speaking about the importance of the continued conversation around alcoholism, and that has greatly affected Indigenous people. And during the time of COVID, there was a managed alcohol program that was created out of one of our northern communities here on Vancouver Island, and it became a managed alcohol program. And it was so necessary because in this First Nations community, the community members that were needing to access their alcohol were jumping into the river because of COVID. They had a lockdown. They were jumping into the river and swimming across to go into the local town to get their alcohol. Extremely dangerous for the people. So the community nurses and the chief and council got together and thought, what are we going to do? How are we going to help these people? We want to meet them where they're at. That's one of FNHA's mandates. And so the community created a managed alcohol program that ended up being quite successful. And these people that pioneered this program go across Canada talking to First Nations communities about managed alcohol programs because it is still such a huge issue in our communities, as much as the toxic drug crisis that's happening. One of the things that I do is do naloxone training, and I go into communities, and it's challenging. I know there are a few Allied Health harm reduction educators in the crowd here, and beginning this conversation is really difficult because there is so much stigma, there is so much misinformation, and there's so much lack of support for the folks that are working and walking with substance use issues. So one of the things that I get to do is do the naloxone training in community and the not just naloxone. So when I'm working in the communities, I'm able to work with my colleague, Edward, and we also hired regional addiction specialists because the wait lists, as you guys know, are absolutely horrible for people to try and get into treatment centers. So we have here on Vancouver Island, we have 2 regional addiction specialists that help First Nations people, communities get through the complex system that is for when people want to go to treatment. So we have those 2 as well. We have a harm reduction practice consultant nurse who works with the BC Centre for Disease Control. So when our First Nations communities want to be able to access naloxone and other safer supplies, they can connect with the BC CDC. I had the pleasure of taking one of our nurses to one of my trainings because I'm not familiar with a lot of the makeup of different drugs and things like that. So our harm reduction nurse consultant was able to fill in that piece for me, so I really appreciated that. And I really enjoy working with First Nations Health Authority because they have meet people where they're at. They have that belief, and we know that all of our Indigenous communities are very unique, and they are at different levels and places of being able to look at the issues and the harms that have been caused since contact and since colonization. So I love going into communities. We provide harm reduction grants to communities, so what they deem as a need to address the harms in their communities is what they use that money for. And some of the things that I do is a lot of our communities through COVID and through the toxic drug crisis have experienced a lot of compounding complex deaths that happen day after day after day after day. And so one of the things that I'm able to do as the harm reduction educator with my colleague, she's a social worker on the northern part of Vancouver Island, is to be able to go and do grief and loss workshops in community. And just recently we were grateful enough and grateful to Mum Stop the Harm. We were able to adapt their book around healing hearts. So we rolled out a program just recently called Healing Indigenous Hearts, and it's about starting support groups for people who've been affected by toxic drug deaths. And so I became one of the facilitators, and we are starting to bring that to the communities so that we can have a support group and have community members as volunteers step up and begin these difficult conversations, as we've been greatly impacted by this. So I'm excited. The list of communities that have come forward to ask for this training is huge. We're grateful that we recently hired another harm reduction educator, so now there are 3 of us on Vancouver Island. And I'm super happy that there is another one, because there was a time where it was just me covering Vancouver Island. So I'm grateful now that we have 2 other people to take on the work, and we also work with our mental health and wellness team. When a community deems a crisis has happened, our social workers are deployed to go in and provide a couple days of emergency support services. A lot of that has to do with the deaths that happen in the communities around the toxic drug crisis. And I really appreciate being able to be a harm reduction educator. My parents had issues with alcohol, and my parents went to the residential school, and they had a tough life, and therefore I had a tough life. Things change in our communities when we reach towards culture as our strengths, and I know that firsthand because there's a lot of things that happen in my life because of the toxic drug crisis that I am a praying person. I do a lot of prayers for a lot of people, and yeah. I love my job as a harm reduction educator, and I believe that FNHA's response to what's happening in our communities has been immediate, and it has been greatly appreciated by all of our communities, because we need to be able to continue to stand together and to remember how we used to take care of one another. I believe harm reduction is something that First Nations communities have been doing for a long time. When I go into communities and I talk about harm reduction, I talk about the culture and the traditional ways when we used to live in houses of 1,200 people, and we knew how to take care of one another when each other was not well. We knew how to do that. Today we seem to have forgotten how to come together and have a meal and share that love and that care and that kindness. So I think I'll leave it at that for now, but thank you for allowing me to share some information. Thank you.
Thanks so much, Marlene. Now I'd like to invite up Brent Johnson to tell us about the Harbour Supervised Consumption Site.
Thank you for having me. My name is Brent Johnston. I'm the program coordinator at the Harbour Supervised Consumption Site here in Victoria on Lekwungen territory, right in the middle. So we opened in 2018. So the Harbour is both a supervised consumption site exempted through Health Canada. So we have an actual exemption to the criminal code for the use and possession of substances on the site. We are also a designated overdose prevention site. We are also a designated overdose prevention site through the Emergency Act that came about in 2016. I'm going to flip through some of these. So when we first opened, it was the injection service opened first, and right from the start, about half of the substance poisonings that we were responding to were occurring outside. So we knew that inhalation was going to be a serious issue as we went forward. This is a shot of what the original consumption booths looked like. They're a little more worn now, but they still look quite similar. So we hand out harm reduction supplies to the tune of about 400 times a day. In addition to that, we see traffic through the site. When we first started, we developed an average of about 150 people a day, and that has sustained throughout, or 150 visits to the consumption room. there's multiple services on site for support. We provide safer education, counseling, referrals. We facilitate access to the street nurse. All of our services are low barrier, or as low barrier as we can possibly make them. So to that end, we have roughly 3,800 registered individuals who use the site. And I can count on one hand how many people are permanently banned from the site. So about 150 people access each day to this day. We see right now about 50 on the injection side and about 100 or so on the inhalation side, and I'll talk a little bit more about that in a second. Most of our clientele travel to the site to use each day from locations in the community. Our stats are roughly 75% male identifying people and roughly 25% female identifying, with a little less than 1% as trans. Since we've been open, we're approaching 300,000 visits total for all reasons. And I should add there that about 30 people a day access just our chill room, which is what we call sort of aftercare, after support, but it's also just providing comforts to anybody who's on the street and wants to spend more time on the site. I should add there that with the low barrier, we do not have we do have wait times, but we do not have, we don't have booth times or a maximum time that a person can spend on site. So there's no time limits to a person's visit. For every person that spends 7 hours in the site, we have 10 or more that spend 20 minutes or less. And so there's always a flow moving through. We also average roughly 12 visits a day to our counselor. And one of our counselors is here, so I hope that's accurate. I know that we have a hard time tracking stats on the site. Part of it is that we don't, as part of the low barrier nature, it's anonymous. And your attendance is private. You don't have to give us your name. You can just give a handle to come in. So we therefore also can't have really 100% confidence in what our data is. We always estimate it's about 10% plus or minus. If I zip through here, so back in 2019, it was very clear to us that we needed to develop an inhalation service of some kind. We tried to locate something somewhere in the community, and eventually just came back to expanding further at the harbor. We took over another part of our building. We ended up displacing some of the teams that were in the building who moved to another site, which was just generally speaking a better fit for everybody. And then we were able to develop the indoor inhalation site. And I'll see if we can get some pictures or where that is. This is our chill room, if you can see that. So it's just an open space for people to hang out. There is a bathroom hidden on that wall as well. Another shot of that space in there. This is the nursing clinic room. There are 3 of these on site as well, and they're also available to community agencies to come in and use. The times are bookable, but also just most of the time available for just a drop in for somebody that wants to see somebody there and access clinic space. This is the inhalation consumption room. So it's we learned from the original setup of the injection room, which is just a bank of booths beside each other, and we learned from the community that they would rather see a communal layout. And we've also learned from our connections with the community of practice across the country that local conditions drive that. So that isn't necessarily a blanket thing that will happen in all communities. And it's one of the things that we advise if somebody are coming to us to develop a new service now, is to say you need to check in with your substance using community. What do they want to see in the services that they have, and how would they like to access those services? So we spent some time to try and build the space up that it would be welcoming and warm. There are 10 injection booths with a maximum capacity of 11 people. Somebody can be sharing at a booth. The inhalation room has a maximum capacity of 24, so there's a lot more flow in there. But again, with no time limits, we also do have people that sleep for multiple hours or things like that as well. And that's just a reality of the service that we offer. In the time that we've been open, We have reversed about 870 substance poisonings, and that is with an intervention, an invasive intervention. So we're basically giving the person naloxone. But we actually also engage with substance poisonings when a person is just not, when they maybe don't need that level of intervention, and they can be prompted for breathing or for support and so on. So those numbers also are quite a bit higher, and we don't track them specifically as a substance poisoning. So we estimate that it's probably, again, roughly the same number as our poisoning responses. The one thing that is an interesting fact about our service is we have very low rates of violence. So we average an assaultive type behavior, assaultive type situation once out of every 40,000 visits, which is very low for a healthcare service. And we're quite pleased with that. We do think it's connected directly to the low barrier nature of the service. That's the ventilation system itself. So our indoor inhalation is heated, and the black cage that you see on the picture there, inside that is our heat exchangers like you'd have in your house, and there's two that just heat the one room, but they're big enough to do a family home. And so it's really quite a significant airflow that's in that space. The space does an air exchange every 2 minutes, so that's quite a bit. And we, as the health authority, we have some money, so we're able to develop services like this, and also to then map out the different variations of services that we can potentially provide, and that other organizations could potentially provide as well, to be able to support that. So we will share information with anybody, anytime, about how we developed our service, and what kinds of things should be taken into consideration for developing something new as well. So thank you. So I was asked to keep it short, so that's it. I hope that's short enough, and that others will have opportunity to talk. And certainly we have our email addresses on here, but welcome questions, queries, comments anytime. Please feel free to reach out if anybody has questions or comments. Thank you.
Thanks so much, Brent. Now I'll invite up Dr. Jill Wieczorek to talk to us about Doctors for Safer Drug Policy.
Doctors for Safer Drug Policy, at its core, we're a group of Vancouver Island addiction medicine doctors, and we work in all sorts of different venues. We do inpatient medicine in hospitals, outpatient medicine in family medicine clinics, in addiction medicine clinics. We provide addiction medicine care in shelters, and yesterday I was providing addiction medicine care in someone's tent. So we do work all over the place. And now we are a much larger group, including nurses and social workers and community supporters and volunteers, and we have some support from really heavy hitters in the community like Moms Stop the Harm and the BC Nurses Union and BC Family Doctors, and we're very grateful for that. The co-founders of Doctors for Safer Drug Policy are three doctors. I am not one of them. I joined a couple months later. Dr. Kelsey Roden, Ryan Harriet, and Jessica Wilder. And it was born out of frustration with, I know no one has seen this before, but harmful government decisions. And so that's kind of where Doctors for Safer Drug Policy started. So around that, Canada has several overdose prevention sites in hospitals, in different sites across Canada. There's one in Vancouver, in Edmonton, Toronto, and Vancouver Island had been promised to have several overdose prevention sites in hospitals, so in-hospital OPSs. These had been promised to Vancouver Island, to several different hospitals, and Island Health was doing amazing work getting towards these and making them happen. At least one of them was very close to starting up when David Eby pulled the plug on that in April of 2024. So all that work stopped. Those programs did not move forward. And that was very disappointing to us as addiction medicine doctors, knowing how important overdose prevention sites are for our patients, and that inpatient addiction OPSs are missing. So we have overdose prevention sites in the community, as we've heard from Brent, and We have them in all sorts of places in the community, and we know that how important they are. But we also need them in our hospitals because people don't just stop using substances when they walk into a hospital, right? So Dr. Heaslip so well explained, addiction, we always have to remember this is a health condition. It is a disease. Drug use, in spite of consequences and harms, is the manifestation of that. And so when people go into hospital with an addiction, they don't magically stop having that, they don't magically stop using drugs. It's like thinking of a diabetic who would go into the hospital doesn't magically stop having high blood sugars, right? So people do use drugs when they're in hospital, and that is probably unlikely to change. One of the reasons behind that is so important to really understand about stigma that people face when they access healthcare in any sort of healthcare setting. And I was going to spend a little bit more time talking about stigma, but I realized the audience I'm speaking to, I think there is a very good understanding. And if you walk into a healthcare setting personally and you feel totally safe from prejudice, from bias, from racism, from stigma, then you are very lucky, and reflect on that privilege. But many people do not feel safe accessing healthcare services, and people who use drugs, people with addictions are often in that category. So when people are in hospital and they're often, my patients have told me many times, I've practiced addiction medicine for close to 15 years, and I have patients telling me regularly that they would rather die than go to the hospital. And I have had patients who have died instead of going to hospital. They just waited too long, and they were so mortified knowing the way they felt that they were going to be treated when they went to hospital. They just decided not to go. And we know this and we see this. And that is one of the reasons when people are in hospital, one of the reasons that they're continuing to use substances is to combat that distress and that they're experiencing. And another reason, of course, is when someone has an opiate use disorder and they're not able to, the pharmaceutical alternatives that they're being given in the hospital are not matching their tolerance, so they're using as well for that reason. But the main reason people use drugs when they go to hospitals is because they don't stop having the disease of addiction, and they're continuing to use. So in hospitals, when there is no overdose prevention site in hospitals, people end up using alone. They use in bathrooms. They go outside. I saw someone just the other day outside of the Jubilee, a sheet over his head, using under a sheet because he didn't want to be seen. I have spoken to many people who live in the Jubilee area, and they see frail patients that are sick, walking down, using in bushes, using somewhere away before they go back to hospital. So this happens. And when people are in hospital already because they're sick, and they're in a frail medical state, they have a higher risk of overdose. And when they use in unfamiliar places, they're also at a higher risk of overdose. So hospital-based OPSs, we know would save lives, but not just would they save lives, they'd also, on a larger level, they would help the system. For example, people would be much less likely to leave hospital against medical advice before they're finished treatment, because they would be feeling more that this is a safe place to stay, right? When people are readmitted to hospital, when they leave, they very often get sicker. They're readmitted to hospital. Every time someone even comes to the emergency department, it actually costs the system close to $1,000. And then if they're sicker because they have deteriorated their health, they might need a higher level of care, like ICU care, and that is much more expensive as well. So allowing people to feel less stigma in hospital, have a place to use safely, not leave against medical advice and get the treatment they need while they're in hospital would certainly help healthcare costs. It would also decrease public drug use, less paraphernalia found in the neighborhoods, for sure, and also less unintentional drug exposure to healthcare workers, which we may hear a little bit more about later. And it would certainly lead to more referrals and treatment and social supports, which we know is a huge part of overdose prevention sites. And most importantly, it would help people engage in the healthcare system and maybe regain some trust in the healthcare system that many people have lost. So David Eby pulled that promise, and 6 months later, Doctors for Safer Drug Policy was founded, and my colleagues initially, started some unsanctioned pop-up overdose prevention sites outside of various Vancouver Island hospitals. And this was not just to save lives and for all the other positive benefits that we know overdose prevention sites have, but it was also for public education and to counter some of the harmful rhetoric that we are seeing in the media, and ultimately to pressure the government to move forward with this. Addiction medicine is often politicized. That is also something that Dr. Heaslip spoke to. And we see that a lot. Politicians are making the decisions, not the medical experts. And that's exactly what David Eby did when he pulled back on his promise of hospital-based OPSs just prior to the election. So do politicians campaign on new ways of treating heart disease? Does the parliament debate best practices for gallbladder surgery? We don't see that. But that's what happens in my specialty. That's what happens in addiction medicine. Politicians are deciding which life-saving tools we get to have in our toolboxes. And we're seeing more and more of these tools being taken away. So doctors have been given a huge amount of privilege just based on our profession alone, and most of us have many layers of privilege that even getting to being a doctor. And at DSDP, we feel that we need to use that privilege to advocate for the tools that evidence shows will help save our patients' lives, help them access better health care, decrease stigma, and provide the dignity that they deserve. And that's what Doctors for Safer Drug Policy is about. Thank you.
Thanks so much, Jill. Now I'll invite up Emily Clayton, who will tell us about the SAFER program at AVI.
All right, hi, nice to see everybody here today. My name's Emily Clayton. I'm a clinical nurse educator with AVI Health and Community Services, specifically with the Prescribed Alternatives programs. And I'll start just by saying I'll sometimes sort of accidentally use prescribed alternatives and safer supply interchangeably. But typically, like when our clients are talking about the medications that they receive, they're going to be calling those safer supply, and then we tend to describe them as prescribed alternatives. All right. I'm from AVI Health Community Services, so it's an organization here in Victoria. Now we've also expanded across all of Vancouver Island, so our primary locations are Nanaimo, the Comox Valley, and then Campbell River also. And we provide a number of health services. Prescribed alternatives is just one of them. But yeah, certainly a lot of different community programming, programming for folks that have hepatitis C or HIV. Folks that are from other marginalized communities can access a lot of services with AVI. So just before we read this fancy poster, I do just want to say that the Victoria Safer Initiative, it's what I really come here to talk to you about today, but I'm trying to also cram in lots of other information because there's so much I want to say about our programs. But I will start just with talking about the Safer Victoria program. So it started in 2020, and it started with a team of outreach workers going in mainly to encampments and meeting with folks that were experiencing compounding marginalization. So they're in encampments, so they're unhoused. Folks were often falling through the cracks and not being able to receive medical services or addictions medical services in other sites. And might have compounding comorbidities like lots of physical health conditions of various sorts or mental health conditions of various sorts. And one of those things that the folks that the SAFER team interfaced with experienced was they were experiencing harms rather from the unregulated drug market and had maybe or had rather experienced a toxic drug poisoning event. Perhaps in the past or sometimes many times per week. So folks are profoundly impacted by the toxic drug crisis. So this small team started by contacting external like primary care offices and providers to see if there would be any teams that would be willing to take on prescribing under the risk mitigation guidance that Dr. Kendall spoke to a lot during the last session, so I'm going to glaze over it today. But the care guidance that encouraged prescribers to in the face of COVID-19, increase in their prescribing of OAT medications like Cadian or mainly Cadian, as well as tablet prescribed alternatives medications like Dilaudid or hydromorphone. So that's kind of how this team started. There was wraparound care, there were outreach workers, nurses, systems navigators that could help folks with accessing social services. Then there also was this trying connection for access to risk mitigation or RMG medications. As this work continued to grow and expand, SAFER partnered with the Canadian Institute for Substance Use Research, and you're going to hear more from some folks from this team later today, so I'll keep this fairly brief too. But in this partnership as well, they partnered with Solid Outreach and started work on what is on the screen here, which is a concept mapping study. So you can see in these slides, there's going to be a lot that you might not be able to see very well. Some of them are quite small. But essentially, the concept mapping study looked at interviewing 63 individuals who use the unregulated drug market and engaging them in asking, what would effective SAFER supply programming look like? So this team of SAFER folks, they wanted to be able to get to a place of opening a physical clinic and having a space, expanding their programming, but knew that we need to do this well. We need to integrate and really base what we're doing on the voices of those with lived and living experience. So this concept mapping study aimed to do just that. So I'll try to keep it brief, but the concept mapping study, there were 3 rounds of focus groups, and again, 63 people with lived or living experience of using unregulated drugs. And what they found out of these three sessions were sort of 6 clusters of messages that these folks all agreed upon in terms of what would make prescribed alternatives programming effective. So the first was right dose and right drugs for me. The second was safe, positive, and welcoming spaces. The third was SAFER supply and other services are accessible to me. The fourth was I am treated with respect. The fifth was I can easily get my SAFER supply. And the sixth was it helps me function and improves my quality of life as defined by me. So on my next slide here, I've just got sort of a screen clip of what the study is called and the citation in case you do want to read that. I just want to again note that in this way, SAFER Victoria is rooted in the perspectives and needs of people with lived experience of criminalized drug use. And we continue to project and amplify the voices of people with lived and living experience in our programming. All right, briefly again, I'll say in the early days of SAFER, there was also a practice brief that was completed, and that was April of 2021. And this was looking at the sort of early outcomes of the SAFER Victoria program, while it was still an outreach-based model at this time. And so participants of the program reported some positive outcomes, namely decreased withdrawal symptoms, safer use practices, and reduced use of illicit substances. Folks also shared that they felt supported by having wraparound supports, so sort of the nursing side of things, the sort of health supports, but also the social services side of things, the systems navigation support, help getting ID, help completing like housing applications or income assistance applications. These are really important. And then, yeah, certainly receiving the actual medications themselves are instrumental in reducing the amount of illicit substances one might be using, or the frequency with which they might have a drug poisoning toxicity event. All right, so in June of 2021, the SAFER Victoria Clinic was able to open, so it went from an outreach-only model to a physical clinic. This was huge. So at this point now, it kind of brings us to where we are today. I'll sort of speak from today's context. The SAFER Victoria Clinic has 6 prescribers, it has a team of nurses, it has a medical office assistant, systems navigation workers, and support workers. And so we're able to offer interdisciplinary care to our clients. A lot of the clients that we work with do continue to be from sort of similar sort of background to those I described at the beginning of this talk. So folks that are often unhoused and experiencing profound marginalization and stigma. And Jill, when you were saying like there are instances that we hear of where folks are not comfortable seeking healthcare elsewhere and would sometimes choose to forego care entirely rather than go to a traditional healthcare setting. We do see that reflected sometimes in the experience, whether it be present or historical experience of our clients. So it's a really special thing to get to share a space with folks and really build a community and some trust with individuals. Yeah, I'm really grateful to get to work in the clinic and to know the staff, to know the clients. It's a really special space. With the opening of the physical clinic, as I said, there are now 6 prescribers. So, you know, in the early outreach days, the staff were having to sort of do outreach to find prescribers who would be willing, whereas now we have six prescribers for our program. And so the medications that I've sort of mentioned before, those risk mitigation guideline medications like Cadian, for example, or tablet Dilaudid, those are still certainly options that are offered at the clinic. However, with having the physical space, we're able to offer witnessed fentanyl interventions, and that's pretty cool and unique in a few ways too. So we have a fentanyl patch, we have injectable fentanyl called sufentanil, and then we have a fentanyl tablet called Fentora. Having the physical site means that we can offer these witnessed interventions, and what that means is that our prescribers, they are very competent, very well versed in providing these types of medications. They have a lot of expertise, and so they're able to safely prescribe these medications. And we also have a nursing team who's very competent and experienced in responding to overdose, but also responding to toxic drug poisonings. So our folks are kept safe while they're using these medications. When somebody started on a new medication, there's like an especially careful routine and process for assessing them pre-dose and then post-dose in order to ensure their safety. And that's a really special thing that we wouldn't be able to do if we didn't have the physical clinic. I think that's what I'll say on that for now. I guess I do actually want to say, I think I glossed over it, but it is so important, which is that the clients that come to our programming, there's no expectation of like a goal for abstinence or treatment on them. The goal of we don't have an agenda. Our agenda is to care for our clients and help them be as safe as possible as defined by them, just like that one quote came out of the concept mapping study stated. So we'll have folks that do come to us and do have a goal of getting to abstinence from the illicit market and maybe getting to treatment. And others might be sort of seeking like a maintenance for now, using less of the unregulated supply and thereby being much safer, but not necessarily fully getting to abstinence. And that's okay. There's, in between those two, there's a whole continuum. So it's just a really excellent opportunity to get to meet folks where they're at. We say it all the time in harm reduction. I cringe when I say it, but it's true. You get to meet folks where they're at. So whatever their goal is when they come to the door, we want to try to help support them with that, with the resources that we have. Okay, and then yes, so this is just a quote here from a SAFER participant. I'm sorry, am I off my time, Jody?
No, it is.
Okay.
I thought that's what was.
No, I'll do a little jig when I'm done. So this is a quote from one of our regular evaluations. We do consistent evaluations with our clients multiple times per year. And a client within the last year said, "The pills are helping with my pain that I have regularly, but they don't help anyway with the dope sickness, which is why I got put on the fentanyl patch, which is starting to help tremendously." So we put it on this slide because it does speak, I think, to that concept mapping quote that said, or cluster rather, that said, right dose and right drugs for me. This is what's going to make a safer supply program effective. And so I think we're starting to see that reflected. We're hearing that from clients, and sometimes it's nice to remind ourselves and see these quotes from clients that it is helping. All right, and so I'm going to try to be brief. I feel like I'm getting to time. But Safer Victoria was the first prescribed alternatives program with ABI, but through sort of learning about the implementation and the successes of Victoria Safer, we were able to expand up island to our other sites. So the Enhanced Harm Reduction Program in Nanaimo, the Regulated Access to Drugs in Comox Valley, Regulated Access to Drugs in Campbell River, and then Safer KTE is sort of it's not a prescribed alternatives program, but rather it's a prescribed alternatives education program that I work on and a few other colleagues where we get to share prescribed alternatives education with external groups in hopes to expand access to prescribed alternatives. Like we're expanding within our own organization, within Victoria even, with lots of community partners, and that's really positive, but expansion is needed elsewhere too. Yeah, and we all share fairly similar program models. We have the same prescriber protocols and clinical protocols, but just the resources that are available and the medication options that are available will differ a little bit by site. So now I'm going to bring us back to another client quote. So one of our participants said, "They, Safer staff, just goes out of their way on just anything. Helped me with, so far, with my ID, my PWD, just making sure I keep up on par with my meds. And they're a good listener. I'm still grateful that I've actually met them. And if it wasn't for them or any of that, I don't think I would be here." That quote comes from the first year Safer Victoria evaluation, and that was done with Safer, but with the Canadian Institute for Substance Use Research. And I hope I'm not like saying any content that might be coming later today, but I'm just leaving that snippet. I think it's a really important quote, and it's what the title of the paper comes from. We do measure the outcomes of our programs, and between 2023 and 2024, across all 4 of our Safer Supply or prescribed alternatives programs on the island, participants shared that 90% reported a reduced use of illicit substances, a total of 70% reported safer drug use practices, about 80% reported decreased withdrawal symptoms, and 87% reported better connection to healthcare services. And these are the stats, or like rather, this is the information that we can sort of capture with numbers. But anecdotally, there's so much more that could be added to that. There's more we could verbally say. There's stuff I don't think we could even capture with words. Like the community that exists in our prescribed alternatives programs, I think is really special. And from my experience, it's unmatched. There's definitely a culture of safety and community and inclusion that I think is really impactful for our participants. We get to share really jovial and fun times. We also get to grieve together when losses happen. The community is, we all know here that they do. So yeah, we can't really summarize that in a number, can we? But it's really valuable. As far as next directions and what improvements could be made, I've mentioned here the first year evaluation. If you'd like to read it, it's excellent. Got the full citation there. We also have there's a study that was recently published as well, and it's about examining service providers' perspectives on early implementation. So this included interviews of staff of the prescribed alternatives programs. And this is a quote from one of the staff, actually, that I think is really, really impactful, and I might just leave you on because I think we're getting there. But it says, "The real crux of safe supply is that there's no one model that's going to be effective. People need choices, and they need options depending on where they're at. Some people will benefit from seeing their doctor. Some people need heroin compassion clubs. Some people need to just go to the pharmacy and fill out some paperwork. Some people need injectable OAT, IOT, tablet OAT. It needs to be a whole continuum." There we go. And I'll say too, we've just published another practice brief, and this one was on expanding prescribed alternatives on Vancouver Island, and it looked at our North Island sites, so I guess mid and North Island sites, Nanaimo, Courtney, and Campbell River. And so it looked into how are those programs implemented and what are the early outcomes from them. This is important because we need to hear these voices, and it's also important because it does give us sort of some guidance regarding how can these programs become applied to like different settings, right? So we've done a lot of work in Victoria. We've captured a lot of information. We've done a lot of evaluation, and that's really great. However, most of the province isn't resourced the way that Victoria is. So how do we bring prescribed alternatives access to the rest of the province? Like, I can't overstate that we need flexible models where folks have greater agency and choice. And again, this might include take-home or carried doses. It might even include non-medicalized models like compassion clubs. And so I'm speaking from a different context, but I just want to name that this is good and it has worked in our setting, but we need so many different models and options for folks. And at the very heart of every single modality, whether it be like an abstinence program, like a treatment program, to the development of a compassion club, or to anything in between those things, like the voices of people with lived and living experience needs to be central. Otherwise it won't work. Okay, that's it.
Thanks so much, Emily. Last but certainly not least, come on up, Evan James, to tell us about the work of Umbrella Society.
Now for something completely different. So I'd say I'm happy to be here, but I'm not really, and I'm not happy that any of us are here, because the fact is this crisis has been going on for so long, and we're not really any further ahead than when we started. The numbers are still skyrocketing, and we're losing far too many people. Like we were saying before, it's preventable, right? Watching this screen is just heartbreaking stuff. So, recovery, sobriety, abstinence, treatment, detox. They're not four-letter words. We can talk about them. I encourage you to talk about them and present those options to people. I think far too often people are not being presented with these options. And what's happening is people aren't given a chance to make changes, to make life-saving changes. And at Umbrella, that's what we do. We try and provide those options for people. We do it through a whole number of different ways. We do it through outreach. We do it through counseling. We do it through our recovery housing, through support groups, drop-ins at our office. We are at the HOP sites. We have a whole number of teams we collaborate on with Island Health. But I think what's going on out there, a lot of the times is there's this myth and this stigma that people struggling, whether they're on the streets or in their own homes, don't want to make changes. And if they wanted to, they could, right? Like you'll see in any of these Facebook articles, I know we're all told not to read the comments because they're just horrible, but you'll always see, well, there's help out there. If they wanted it, they could get that help and they could change. They could be in rehab the next day. It's not true. It's not true at all. But and the fact is, a lot of these people do want to make changes, right? And I think that's what's being missed. People don't realize that the people out there are not happy with the way things are going for them, and they do want to make changes around their substance use. But it's not as easy as it's portrayed, right? And a lot of what we do is navigate this broken system with not enough beds and not enough help out there. Detox, there's a huge lengthy wait to get in. There's not enough beds. They are particular about who's allowed in based on what substance they're using. And so we know when people want to make changes, that window of opportunity is so small sometimes. You know, to tell someone that they have to wait 3 weeks, they have to wait a month to get into detox, it's heartbreaking, right? And you can literally see the hope leave someone's eyes. And so the people out there know the reality of the situation. They know how long it takes to get into these places, and then what, right? So someone goes into detox, they get everything out of their system for 7 days, and then they go back to the unsafe environment they were in before, surrounded by substance use. There's no chance, right? And we tell them, okay, now you have to wait another 3 months to get into treatment. And how are we gonna get you into treatment? So, you know, I've heard a couple times mentioned today that addiction is a medical issue, right? We view addiction as a medical issue. Well, it's not treated that way in getting help for it. So when it comes to treatment, there's cost, right? So we got to look at, if someone's on income assistance, there's a certain number of beds they can get into. If they're not, we're looking at private pay. Most people can't afford that. What about everybody in between? So we're struggling to navigate that whole world and that whole system too. The reality is there's not enough beds out there, and we need a whole wide variety of approaches. We're too often we've seen that old method of, if someone goes through treatment and relapses after, we say they did something wrong or they didn't do the work properly. That's not the case. We just haven't found the right solution for them yet, or the right approach. There needs to be so many different options, so many different approaches, so many different timeframes, and we just haven't seen that. And I don't understand how, we can look at how many people we've lost since this crisis started, and why would the government not pour every resource they have into increasing the number of treatment and detox beds and into helping people immediately when they want to make changes and want to stop using substances. I just don't get that. I don't get that piece, why we haven't seen that same attention and those same resources poured into recovery. As far as evidence, we see evidence every single day at Umbrella. Half our staff were Umbrella clients, myself included. So we know what we do works. We know that recovery works. We know it saves lives, it transforms lives. And the evidence is out there. Unfortunately, we also see the other side of it, which is how many people we are losing and how many people we are losing that wanted to make changes, right? And I've lost count of how many people I know and love and care about that have died from overdose. And a lot of those people are on wait lists, right? That's the tragic part to me. Not that any's more tragic than the other, but the fact that there were people wanting change and that help wasn't available to them, and they died while they were waiting, right? And those are preventable deaths that we see continuing every single day. I know I'm supposed to talk about the organization I work for. I came up here and just decided to rant a little bit, but Umbrella does do great work in the community, and we continue to try and reach as many people as we can. And I appreciate everyone else that's up here doing work to save lives, and I hope that people are listening and that we continue to see more change and more resources poured into recovery. We're going to keep promoting the fact that recovery works and it saves lives, and that we need a heck of a lot more of it. And I don't think, like I mentioned at the start, talking to people about making changes in their substance use, people are often scared to do that. They're scared to bring those conversations up, and it's not, people think sometimes you don't want to insult someone, you don't want to offend them. It's not insulting or offending. Like, believing in someone's ability to make changes is the best way you can honor them, in my opinion, and thank God I had someone that believed in my ability to change, because I didn't have any hope or belief that I could stop using substances. But I had other people that did, and they showed me that belief and that care and compassion, and we continue to do that for other people, and we believe in their ability to change, and I hope more other people can also believe in people's ability to change and be cheerleaders for them and have those difficult conversations and point them in the right direction and walk alongside them and help them to make changes too. So that's it. I know we're over time. I'm not going to continue ranting all day, but yeah, thanks everyone for being here, and hopefully we can honor those we've lost and continue to help more people to find recovery. Thank you.
Thank you, Evan. That was an excellent closer for this portion. We're going to take a short break, be back here at 5:15 for what is promising to be a very lively discussion with Corey Ranger, Jen Bowles, Reka Gustafson, and Karen Urbanowski. So stick around for that. It's going to be on evidence, lack of evidence, and moral panic, which is one of the big factors in a lot of the problems that we have right now. Really excited to introduce this panel. We have with us today from right here, we have registered nurse Corey Ranger, president of the Harm Reduction Nurses Association. He's going to be our moderator / participant for this dialogue. We've got Karen Urbanowski, Canada Research Chair in Substances, Addictions and Health Services, University of Victoria. Next to her we have Jen Bowles, University of BC Research Scientist in the Department of Medicine, BC Centre on Substance Use. And at the end, we have Dr. Reka Gustafson, Island Health Chief Medical Health Officer. And I'm just going to turn it over to Corey, and they're going to have a fascinating conversation.
It's so great to be able to have the opportunity to speak with you all today. As Jody said, my name is Corey Ranger. I use he, him pronouns. I'm a registered nurse, and I'm the president of the Harm Reduction Nurses Association. I usually reside on the unceded territory of the Cowichan tribe in what is colonially referred to as Dungan, but I'm very grateful today to be on Lekwungen-speaking people's traditional territory. I think it's important that we all have an opportunity maybe at the start to reflect a little bit on what we've heard. And today's session is about evidence and services. And so let's start off this conversation with, what do we know? We actually know the drivers of the unregulated drug poisoning emergency. We know after 8 years, 10 months, and 5 days of a declared public health emergency, what is killing 16,000 British Columbians. We know what is driving this crisis, and we know that what is driving this crisis is a drug supply that is criminalized, one that is contaminated with unpredictable and unwanted adulterants, one that offers no agency of choice for people who are compelled to access this supply. And for those of you who think this is an issue only for opioids, we also know that people who use stimulants are dying because stimulants are also contaminated with fentanyl. This is a drug poisoning emergency. And we also know a lot about the services that were just discussed earlier today. In fact, there is a lot of evidence that supports all of the services that we heard about. When it comes to prescribed alternatives, there are over 93 peer-reviewed journal articles, evaluations, scoping reviews, evidence briefs that all demonstrate the potential to reduce the risk of harm and death. We've seen large-scale population studies, which some of our panelists here have been a part of, that have demonstrated a reduction in all-cause and overdose mortality risk. We have studies that show that when people access prescribed alternatives, they're actually more likely to stay on their addiction medicines like methadone, even though there are some who would like you to believe that prescribed alternatives impedes access to recovery. We know a lot about supervised consumption services and overdose prevention sites. We know that those services save lives, improve the health and well-being of people who access them, improve community health outcomes, and save the health system money. We know that access to harm reduction services like needle distribution programs significantly reduce the risk of transmitting HIV and hepatitis C. These are public goods. Less HIV and less Hep C is good for everybody in the community. And so we find ourselves at a crossroads here because policymaking is not being driven currently by evidence. In fact, what we're seeing is a significant amount of policy regression on the heels of moral panic. We're seeing harm reduction kiosks being shuttered overnight because a conservative MLA tweeted about it. We've seen the full rollback of decriminalization because some people videotaped someone smoking crack in a Tim Hortons, even though it was already illegal to do that, even under decriminalization. We've seen doctors risk their jobs to set up overdose prevention services outside of hospitals while larger institutions lag behind in their response. And so we have to ask ourselves, if it's not about the evidence, what is it? There's a concerted effort right now, and maybe for the last 2 years, to convince the people of British Columbia that they're unsafe. And the reason why they're unsafe is because of people who use drugs and the policies that supposedly enable them. This is misinformation, disinformation, and moral panic. And when we're able to tap into people's fears, when we're able to convince them that they're not safe, then we're able to create a public outrage that's strong enough that it'll actually change voting patterns. And when voting patterns change and people feel their ability to retain and get power slip, then they'll make policy changes. And so this is a moral panic. This is about power and the ability to retain power, and it's important that we name that. And I'm really excited to be passing this over to Karen Urbanowski for her thoughts. But I want to just add this comforting fact that the first step to fighting a moral panic is understanding it. Thank you.
Regretting slightly being scheduled to follow up Corey. That is not easy to do. So hi everyone, I'm really glad to be here. I'm Karen Urbanowski. I am a scientist at the University of Victoria. I'm located at the Canadian Institute for Substance Use Research, which Emily spoke about earlier today. I've been working for about 2 decades in the area of substance use services research. Pull that a little bit down. And what that means is my research tends to focus broadly on what types of services are out there, less about the sort of clinical elements of what works and doesn't, but how services are fit together to create a system, what multidisciplinary collaboration looks like within services, how services with different types of goals and purposes and functions work together to create a system. I'm one of the co-leads of the provincial evaluation of prescribed safer supply. I've been doing that work since 2020, and I bring that system lens to the work that I do in that project. So anytime any new intervention of any sort is added, it's not added in a vacuum on its own. It's added into an existing system with strengths, with gaps, with challenges, with successes. And these services all work together to create a support network for folks so that they have options to choose depending on what their needs and their past and their goals are. Now, I will say, as part of the Prescribed Safer Supply evaluation, what we've been able to do is to connect nationally with folks working in other provinces to look at the national evaluation of safer supply that's going on in Canada. And we've been able to scale down and also work locally. So we contribute to to working with Vic Safer on the evaluation and some of the publications that you saw earlier today. That's really given me a pretty broad landscape to draw from, and prior to that, the years of evidence the years of experience I have in sort of creating the evidence, reading the evidence, and engaging with it. And I think one critical point that I'd really like to make, which actually dovetails perfectly with what's already been said today, is there is a wealth of evidence that we can draw from that says there is no one intervention that is going to work for everyone. People need options, and they need them the day they decide they want them. So if you wake up in the morning and you want or you need supports of a certain kind, what's available to you that day that you can go out and access in a safe way for you, in a way that respects your culture, your gender, and so on? This is the truth. This is the truth. This is the nature of the health condition that services are there to create, is that that's what we need. And instead, I think because of years of crisis, because of a scarcity model of service provision and just fear around looking at the photos, seeing the volume of death, seeing what we're seeing on our streets today with the housing crisis that's coming to play here as well, what we see is camps forming. We see a loss of nuance in the way that we understand evidence. And so I just want to make the point that evidence in favor of one intervention it's not evidence against another intervention. Finding multiple interventions work is not contested evidence. It doesn't mean that one study was wrong. It means that people need to have options, that it means we have more tools in our toolbox. And so I'd like to return, what I'd really like to see is a return to some nuanced discussion around how the services that fit under a harm reduction umbrella, how the services that fit under a treatment umbrella actually need one another in order to function, right? And a good example of that is one that came up just that you mentioned, Corey, is that we have seen increases in OAT retention associated with hydromorphone prescribing. This is a service that is being called upon to evolve to the context of the toxic drug supply and to keep up with what the community needs. And Prescribed Safer Supply and OAT can work together in that way to see that happen. And that's just one example. There's many, many examples of the ways that the outcomes of an evidence-based service are maximally achieved when it's embedded within a system of other effective services. I'll leave it there.
So my name is Jen Bowles, and I'm a research scientist at the BCCSU at University of British Columbia, which I know was already mentioned. My thesis, when I was working on my doctorate, I was working with an advisor who, this is back in like 2011, and this was in Philadelphia. I grew up in New Jersey. And I saw that my advisor was doing work on naloxone distribution, right? And harm reduction was something that I never really had to struggle with. It was a concept that was introduced to me, and it just made sense to me. But I understand that not everybody is quite there on board or might never really fully come around to supporting some of the work that we do. But I feel like it was something that was really pragmatic and just made sense to me. And what I liked about the opportunity to explore how naloxone was functioning within the community is that it was taking a resource that typically had to be relied upon to receive through the medical system, right? And it was giving it to people directly so that they could reverse overdoses among their network of peers, or to it could be to a complete stranger who was overdosing. And what the impact of that was, and among people who use drugs. And this was initially happening kind of in like an underground circuit, right? Like there was authorization from the government in order to do it, but the way that it was playing out within the social networks of people who use drugs in Philly is it was like, where did you find out about getting that, they called it the come back to life drug. They're like, where did you get that come back to life drug? And so people would tell them, oh, you can go over here to this harm reduction center, which was also a syringe exchange program. I say exchange specifically because it was not an access program. You had to exchange in order to get syringes. But you could get naloxone there. You could get trained in like this 5-minute quick, like this is how to recognize the signs and symptoms of an overdose. Here's how to prevent one from becoming fatal with this drug, naloxone. And I started working kind of within the fringes of harm reduction in the US as a result of this. It was a bit outside of the medicalized system and understanding what are the ways and means that people who use drugs are working together to keep one another safe, right? That having to rely upon a medicalized system that has been mentioned previously is not always trusted, and for very good reason, right? Like people sometimes walk into a hospital and are treated terribly. And so there's no impetus to feel like this is a space of healing. And so I feel really fortunate that I'm somebody who, when I moved to Vancouver, I got to be one of the evaluators of DULF, of the Drug User Liberation Front's Compassion Club. And I'm also currently evaluating Road to Recovery, which was mentioned here before. So I'm kind of seeing this spectrum of the Compassion Club approach all the way through to this like new clinical model of treatment and of recovery, and what are the different ways that both from a medicalized perspective and through communities of people who use drugs, we're trying to reduce the harms that are growing more and more complex by the day. And we hear this all of the time in research. We hear complex withdrawal. We hear about complex wounds. We hear about the complex toxic drug supply that consists of, new things that we're learning about on a daily basis. And so something I want to mention about with the Compassion Club that it really sought to do was take away some of that complexity and bring us back to a simple kind of like, here are the substances that it is that you're seeking, and see how it was going to stabilize people's lives. I'll leave it at that for now and pass it on to Rekha. Thank you.
Hi, everybody. I'm Rekha Gustafson. I'm the Chief Medical Health Officer for Island Health. And in that role, I'm a public health doctor, which makes me different from the addiction medicine colleagues who spoke before, who are providing care for individuals or groups of individuals. As a public health doctor, where our patients are communities, and our medicines are communication and organized activities of society. And so one of the things that we tried to do is, rather than looking at what an individual did, we look at what kind of environment do individuals and communities exist in order to make them well or less well. And so the reason I'm talking about that is because we had a lot of really great presentations about individual care and what kind of programs work for people. And complementary to that is what we as public health doctors do, which is really try to see what drives what we call dominant narrative. So what people talk about, what people think about, what they talk about and they think about drive the decisions and the policies that they make that either make us less healthy or more healthy. And one of the reasons that's important for substances is because substances exist at a societal level. They're an inherent part of our society. And I mean that in general for all psychoactive substances. It's part of the human experience. But one of the reasons that we've landed where we've landed today, when you actually look at the history of where we are, is that we actually look at substances in very, very different ways. How we look at one substance versus another is a result of history and perception, often which country tried to force which other country to use their opiates. England shall not be mentioned here. And as a result, we landed in 2016 when the emergency was declared in a situation where if you actually look at the data of how substances harm our health, the two top substances are opiates and alcohol. Yet alcohol and opiates are treated completely differently by our society. One is legal, celebrated, and in fact, we have stated goals in policy goals to increase consumption, to make it easier to buy alcohol. The other substance that's harming our society is really significantly, of course, is opiates. And that one is illegal and it's criminalized. And we create a situation where our policies, which make them illegal, makes it impossible to gather data really about who's consuming it, how much are they consuming, where are they purchasing it, what's in what people consume. And sometimes I think about these two extreme approaches to substances and think, both harm people, the difference is who makes the money. And one of the reasons that we've actually, as Dr. Heaslip mentioned, we wrote a report on these substances is to try and actually start to change the public perception of what these substances are. There are no good substances, there are no bad substances, there are just substances as part of human experience, and how we as a society choose to treat them determines whether or not we maximize or minimize harm to people. There is not morally superior substance or a morally inferior substance. There is not a substance that makes you a better person if you use it and a worse person if you use it. They simply are. And one of the last things I want to share is that the last substance, and I want to compare this to, is tobacco. About 50 or 60% of the world of the Western world was using tobacco in the 50s and 60s. It killed one out of two people who used it chronically. And we as a society, through our organized efforts, decided to do something about it. We decided to have a strategy that had health at the center, and we decided to use the tools that are available to you if a substance is legal to minimize the harm of society. We used taxation, we used a ban in advertising, we used changing the actual content of the substance, using age limits to make sure that young people couldn't purchase it, and we denormalized the use of tobacco. And over 50 or 60 or 70 years, we actually changed the trajectory of the biggest substance-related killer in our society. So one of the reasons that we did put this report out is to try and challenge some of the dominant narratives, some of the moral panic, some of the substance-specific hysteria that's out there, and really bring it back to that recognition that we, through the organized activities of society, know what to do, and we are choosing not to. And which means that we have the ability to change that. We can choose to do it. We can choose, but one of the most important things in the long run is that the tools that we know that work, which is controlling what's in the substance, controlling taxation, pricing, availability, and advertising, can only happen for a substance that's legal. And as long as a substance is illegal, we are consciously forfeiting the tools that we know that work. And so that's really one of the areas of thought and evidence that we're gathering. As a public health doctor, I have the privilege to gather that data, to share that data, and I really appreciate being able to talk to you about it and join my esteemed colleagues, academic colleagues, to share that part of the evidence. And and I just would like to, one last thing I'd like to say is that one of the things that comes with that privilege is a responsibility, and one of the ways that I had the ability to use that responsibility before I was the Chief Medical Health Officer here is I got to work at the BC Centre for Disease Control. And during the pandemic, you heard about deaths related to COVID every single day. And we were able to use vital statistics data to look at what was actually killing people during the pandemic. And during the pandemic, the top cause of death and top cause of potential years of life lost was overdoses. And it's one of the things that I think was really, really important to try and make sure that in our enthusiasm for pandemic control, we didn't actually cause greater harm. And I don't think we succeeded at that, but at least we had the opportunity to name it. Thank you.
Thank you so much for everybody's kind of opening remarks. I think I'd love to just kind of dovetail a little bit off of what Rekha just said and talk a little bit about your example with alcohol, which is celebrated. And last year, BC Drug Checkers released a fact that stated approximately 3% of all stimulant drug samples contain fentanyl. And I think about that a lot because 3% doesn't sound like a lot, but when you think about the 225,000 British Columbians who access unregulated drugs per year, that's quite a bit. And if you could imagine going to the liquor store after this event and buying your favorite bottle of wine and you knew that there was a 3% chance that your bottle of wine contained fentanyl, we would probably see a lot of outrage. We would see a significant outcry. We would also see product recall. We would see warnings in public advertising. And we don't get that with the unregulated drug supply. And so I'm interested to know from the panel, why the disconnect? Why do we know so much about what's causing death? Why do we know so much about what potentially can help stop the deaths? And yet we're not seeing a fulsome investment in those changes.
Something interesting happened on my way over here. I was on the ferry this morning, and this ties into it, I promise. And I met this couple that were headed over to Tofino for a birthday. And one of the partners was really on board with harm reduction, and the other absolutely was not, and lives right outside of the downtown east side in Vancouver. And we just got on topic without me even mentioning what my work is or like anything about my background. It came up by virtue of this person mentioning where they lived, and that if they were to turn left out of their home, it's kind of like, you know, fancy stores and restaurants and places to get drinks versus what he referred to as the apocalypse if you were to go the other direction. And a lot of what the conversation centered around was, aren't all, you know, these Band-Aid services just making things worse, right? And we were talking about how it's become more exposed potentially by virtue of the housing crisis, right? Which we can't say is about drug use, right? We know that there's issues of poverty that are framed as drug use issues. And what this person's partner said to them was, a bar is a supervised consumption site. And that's probably something all of us in here have heard many times, right? But to this person on the ferry, it was a light bulb moment. Like, I'm not kidding. Like, and I'd never seen anything like he kind of sat for a moment and then started giggling and was like, I guess it kind of is, right? And we talked about these examples of like how the bartender is, you know, has an obligation around making sure of your welfare and safety within the space. And I kind of returned to something as simple as that because I hadn't seen in a long time somebody be so taken by something that I think that we have like come to see as like really just this simple part, almost like, you know, the meeting people where they're at when it was mentioned in a previous panel about it's something we hear really often, but I don't know if it's always part of the public discourse or narrative. And that's not to say that we're in an echo chamber per se. I think that there's dehumanization that's part of, you know, and stigma as part of this moral panic that leads to people not necessarily having their ears open for what some of these comparisons might be. So I'd love to hear what my other panelists have to say about that too.
One is the enormous power of the status quo. One of the things that I find really difficult to communicate is how profoundly unacceptable the status quo is. And so you try to propose a solution that is out of the realm of what people are used to, and there is all the risks associated with that solution. People don't put that against the risk of the status quo. And so I think one of the powerful things, and again, the two addiction medicine physicians spoke about this, is drawing parallels to things that people are used to is potentially a way of starting to normalize some of these things. Harm reduction is a chronic disease management. I sometimes think about Ventolin or steroids for asthma. Ventolin is harm reduction, steroids is treatment. Nobody's outreached by either. I do think we have one really big issue, though, in the interventions that we have put in place, and I've got a bit of an analogy for it, which is a question of dose. We have a very large issue, 225,000 people, and most of the interventions we've rolled out have occurred in really a pilot sites in very small doses. And I drew this analogy to antibiotics. If you have an infection, you could have the right antibiotic, but if you don't give it in the right dose for the right duration, you won't treat the infection and you'll develop resistance. And I think what we've done societally is that these interventions that in themselves are effective, we have excellent evidence, but we haven't rolled it out at the right dose. So independently of the interventions, due to things like border closures, the overdose crisis got worse, and people associated these small interventions with the worsening of the overdose crisis, to the point that I was in Ontario with my public health colleagues, and they literally had the narrative, well, BC rolled out a safer supply program, and look what happened there. And I thought, okay, so the problem with this that we didn't roll it out, it's not really safer supply, and it has nothing to do with the trajectory of what happened. So I think we have some really amazing projects, we have some really amazing programs that are serving the people that are able to access those programs. But the notion that we've rolled out in British Columbia a safer supply intervention at the scale of the problem is really, really flawed. And I think we're actually fueling some resistance because people are making false associations.
Yeah, I agree wholeheartedly, Reka. In some of the work we've done, we've shown at a population level, and we do this by looking at administrative data, which gives us information on every person in British Columbia who had access to prescribed alternatives, prescribed safer supply, however you want to name it. And it's well below 10% of the estimated need. that's out there. So 10%, less than 10% of folks who are at risk of overdosing were getting these medications. Now, that's actually very interesting to me because throughout my career, I see that statistic for pretty much all treatment services. Any kind of services for substance use, that less than 10% get it. Okay, so we're pretty good at getting about 10%. So what's happening with the rest of the population? When you introduce a service that is a little bit outside of the norm and it, like prescribed safer supply was, and people don't see things getting better right away, same thing happened with decrim, it becomes the scapegoat. And it becomes the scapegoat through the processes that Corey highlighted around moral panic. We were being, at the same time that we were seeing a worsening of a crisis and we're seeing interventions introduced that do help, we see the rhetoric and we see the fear growing and we see, I completely understand the urgency of the situation, the desire for a silver bullet, the desire to see change happening now. And structured research takes time, which is very frustrating. It's frustrating for me, and I'm doing it. However, at the same time, you know, thoughtful research is coming out that is showing this saves lives. Prescribed safer supply saves lives. There are people alive today because they got prescriptions, and it didn't matter. Didn't matter. It's not about evidence. And so one of the conversations I've had with Corey before is, okay, so we know what works, we know what causes this, as Corey very eloquently started us with. We know what works, we know what's causing the problem. We're not really able to get there. I'd like to see a shift away from the kind of research I do, where I'm looking at interventions, to seeing, okay, so how do policy processes work? How does moral panic work? How does media and representation and power operate in society such that the evidence isn't being used? I want to see that. I want to see research that tells us how do we work with people with different types of opinions and help to inform them, because we know that education alone doesn't work. We know that. It doesn't work for the reasons that Corey's already outlined. So how do we go about that? How do we understand how power infiltrates and changes the narrative such that we are now unable to get our research findings incorporated into policy when the outcome is death? We're not talking about different ideas of recovery. We're not talking about what your own quality of life entails for you. We're talking about keeping people alive. And the loss of life isn't enough. And I think we need to talk about why that is. Because for me, that's the foundation. If you find something that is preventing people from dying, that's the foundation. The rest is details. How you do it, how you implement it, who does it, where is it done. That's all details that we worked out. But if you got the foundation that it saves lives, what else do you need? Why isn't that enough?
In my master's, I'm studying moral panic and misinformation and disinformation and what the policy implications are of a moral panic. And so I could talk about this for a very long time, but I promise I won't. What I will say is that there's one important piece that makes disinformation effective. There's one important factor that makes a moral panic gain traction, and that is that it is usually wrapped in truths. And so there are things that are happening right now that are very distressing. It is not normal to see the amount of people outside suffering in the elements, deprived of housing. It is not normal to see people rendered incapacitated on the streets for hours on end, unresponsive but still breathing because of benzodope in the drug supply. That stuff is scary. And so people are afraid of what they see. You see people driving down Pandora and they might have an angry reaction to seeing visible poverty, but a lot of that anger is rooted in fear. It's fear because we're seeing people in the worst possible conditions in a society that's supposed to have universal access to healthcare, in a society that talks about the right to housing. And so a moral panic is effective when it taps into people's base emotions. And so one thing that I think would be really helpful to kind of part folks with, because I know we're wrapping up for time here, is that we all actually can play a role in combating moral panics. And it doesn't have to be a big one. It could actually be as simple as having a difficult conversation with someone. And knowing that at the root is fear, you can actually understand that just openly defying someone's statement, saying, no, you're wrong, you don't understand, that's not what the evidence tells us, is not effective. And it actually will make people pit in more on their positions, right? Even in the face of insurmountable evidence, they will pit in on that because they feel attacked. And so instead, the next time someone says to you, boy, I drove down Pandora, what a shit show, right? Thanks a lot, Trudeau. Say, it's really scary, isn't it? I'm really worried about the people who are out there. I feel similarly. And then move into, what do we know about this? Bring people along, give them the opportunity to be wrong. Otherwise, they will continue to be wrong, and they'll do so to the detriment of the people that we love and care about. You can combat moral panics by writing a simple letter to the editor and saying, this is misinformation, this is what the evidence actually tells us. When they use a really stigmatizing photo in a news article about harm reduction, email them a copy of some different pictures that they can use next time. There are a lot of little things that we can do that help shift the narrative. I want to say thank you so much to our panelists today. I want to say thank you so much to everybody here for your time and your attention and your thoughtfulness. Thank you to Peers for putting on this important session. And everybody who's a service provider out here who's helping, whether it's treatment, recovery, and harm reduction, or a little bit of both, thank you for all the work that you do in the face of such politicized time. It doesn't go unnoticed. Thanks.
So thank you all. I'm going to hand that mic over to Peers Victoria Executive Director Lee Elliott to thank our cultural workers and introduce a couple of last special guests before we close.
Thank you so much, Jody. Thank you everyone so much for coming. I know that there's people filtering out. I just want to take a moment to thank all the speakers today, the cultural workers who came and shared their medicine. And I also want to thank the organizers for today's event, Jody, who is our fabulous MC, and Rachel and Sophia, who are in the back. And yes, thank you. And at Peers Victoria, we really believe in the power of art and advocacy and the combination of the two. So we wanted to end today, in a bit of a artistic note and uplift folks before they head out. So I'm going to pass it to Sky and Sarah.
Thank you. Testing. Okay, so where are you going to sit, sweetie? Okay, perfect. Hey guys, I'm here to finish you. Eh? Yeah, you like that? So I've written a piece that they asked me to perform. It's a short spoken word poem, but I've incorporated it into a burlesque act, so I thought it would just be do the whole thing. I won't be burlesquing, so you'll have to imagine me naked. And guess what? I'm imagining all y'all naked too. Yeah. Drug use and sex work have so much in common, and the big one is stigma, of course. Criminalization equals stigma equals death. And that's the same for people who use substances and people who work in sex work. So if we want to reverse that, we need to go decriminalization equals destigmatization equals life, right? Woo! So this, I'm not the best singer, but I do have something to say, so I appreciate you listening while I sing. My good friend and Peers board member, Sky, is joining me. And this is, sex workers don't have a lot of anthems out there. And one of the ones that we do know of that speaks to a sex worker's experience or speaks about sex workers, it's Roxanne. And I find it really patronizing. And you know what? With that in mind, I want to say, fuck Sting and fuck the police. This is Roxanne reimagined. Yeah. This one's from my working girls, from my twerking girls, and rent boys and boy toys, and all those employed in the joys of sex and passion. It's intellectual, you see, 'cause fast money's quick, 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 quick. No one said it was easy. Let's raise them up. This one's for my jerking girls, and they may be clerking girls, but only in daylight. Girls with the curves, they got nerves. They're real, legitimate entrepreneurs, and I believe they deserve to speak their stories with pride and hold your heads up high. Roxanne. Put on the red light, right? The day it's over, share your body with the night. Roxanne, you should wear that dress tonight. Walk the streets for money. It ain't wrong, you know it's all right. Roxanne, put on your red light. Roxanne, put it on. This one's for my networking girls and the lost boys and the loved ones, taken missing, friends and family, the spirits of our communities, all lost in the hustle, caught in the game, because they were treated as prey. Don't let nobody look through you. Let nobody talk down to you. I have to tell you just how I feel. Don't let no one take away your voice. I know your mind, it's made up. Someone's at the door. So put on some more makeup. I have to tell you, 'cause it's how I feel. You can do it, it's your own choice. Roxanne, put on your red light. Roxanne, put it on. This is the part where I would get naked. Baby, just put it on. All right, you're right. I'll just take these off. Ooh. Baby, just put it on. Hustling, hustling, always hustling.
One more, baby.
One more, here we go. Baby, just put it on. Sex worker rights are human rights. Say it with me. Sex worker rights are human rights. Thank you, friends. Thank you so much. Destigmatize the labor.
Thank you so much, Sarah and Sky, and thank you.
Thank you.